from Alain Maladirar, Luxembourg, and from Eurodis to the floor. Thank you.
Thank you, Anna and Maurizio. Okay, it's a pleasure for me being here today as representative of Eurodis, because I have been, during years, a lot of time representing the European Commission, representing Alain Maladirar, and today is representing Eurodis. And I think this is something really important for us. If I reach to... This one. Okay. And this one is back. Okay, that's perfect. Well, I suppose that in a way or another, you know very well what is Eurodis. Eurodis is the umbrella organization hosting all the different federations at national level, and also the alliances at national level, and the federations for specific rare diseases existing in the European Union and beyond, because we have also members, a total of, as you can see, more than 1,000 patient organizations, 2,500 patient groups, representing 74 countries, from which 28 of the European Union. Probably that was done at the moment of UK was always member of the European Union. But you see that we have also 44 national alliances, as Alain Maladirar in the case of Luxembourg, 72 European federations, etc., etc. Also, we have a very important staff membership, which is working for Eurodis in several cities, in Paris, in Brussels, and in Barcelona, where Gülsin is acting as one of the important persons in the staff of Eurodis, of course. Well, why newborn screening is a priority for Eurodis? I think it's very easy to understand that when you are really every day confronted with families, when you are every day confronted with the need of doing something, and with people that is asking to you, please help me to do something, one of the alternatives that you can give to these persons is, of course, we can do something, and it will be very, very important if we can do it as soon as possible. And as soon as possible, it means to do an early intervention when it is possible to do at the moment of the birth, and that can, it's obvious, change the life of the person. I will not insist in the matrix which compare the different situations in Europe. What I can say, it's very clear, is that the situation is a total inequality between the different member states, and it's certainly a tragedy that the evolution of your disease and the evolution of the life of your family will depend from the country, and sometimes from the city or from the region where you are born. This is something that we want as much as possible to change in Eurodis. Well, we are now in 2022 discussing about newborn screening. It's not the first time, really. We had a very important occasion and a very important moment in 2012 and in the period between 2009 and 2012, when the European Commission at the time has organized a tender that was performed by the Istituto Superiore di Sanità in Italy. And this very extensive executive report produced for the European Commission in 2012 contained at the time a very good description about the different situations in the different member states and how can organize something similar to a European framework for newborn screening. These conclusions of this executive report were presented to the USERT. The USERT was at the time the European Union Committee of Experts of Rare Diseases. It was a body very active where patient organizations, member states, scientific societies and other stakeholders were represented. I think the only survivors from this USERT from the year 2012 are Milan Maciek and me. I think there are no other survivors in the room. But Mauricio participated in certain moments also in the activities. And Dorica, of course. Dorica was also in certain moments linked to this committee. It was very nice that we had during a lot of years this USERT. And in the USERT in 2013, we had an extensive and very hard discussion between member states and the European Commission in order to promote for the first time a European framework for newborn screening. And I should say that, unfortunately, majority of member states and majority of experts rejected this possibility. I think, well, at this moment I was representing the European Commission, and I can assure you that it was a professional frustration for me, because I think it was a good moment. It was a good moment. And we lost this because probably we don't have the support of the president of the USERT, first element, because several very important member states not supported a European framework for newborn screening, because they say, oh no, you want to impose things that we don't want to do, etc., etc. This type of arguments, this type of reasons that probably in a discussion today, it will be probably repeated. Then it's something that you should always not forget. We had a very important discussion with the member states about creating a European framework for newborn screening, and that was rejected. That's something that you should not forget, because only forgetting the defeats that we had in the past is the best way to repeat the process that can lead to a new defeat. And then it's important to retain this experience and this situation that happens in 2013, 9 years ago. Of course, the user adopted an opinion of the user as potential areas for European collaboration in the field of newborn screening. That was adopted in July 2013. You know something about this document? Nobody knows nothing about this document. It has never been implemented. Any member state has used nothing of this document. Even if you read this document 9 years after, you say, well, it's interesting what we said in 2013. It could be even feasible to implement today. But unfortunately, during 9 years, the member states have completely ignored this opinion of the USERT from 2013. I insist, important to retain the past experiences, especially the frustrated past experiences, because it's the only way to avoid a similar situation. That's for the past. Now, what happens now? Of course, now Eurodis decided in a certain moment that this situation is not possible to continue like this. Eurodis decided to create a Eurodis newborn screening working group with a task of really supporting the efforts of the member states, sharing knowledge, sharing capacities, sharing possibilities of expanding new diseases, new practices, etc. And this Eurodis newborn screening working group, which is not a group pretending to lead nothing, it's a group that pretends to be an actor, one actor more, as it could be the International Society for Newborn Screening or Screen for Rare, etc., etc. It's an actor, an important actor. It's composed by 24 members. Gülsin and me, we have the pleasure to be part of this group and to act as a working group. We have, in a certain moment, decided to, in December 2019, to start a process of consultation with the national alliances, with the European federations from the different diseases, in order, and with the companies. That was important, the ERTC, Newborn Screening Workshop, that takes place in Barcelona, I think, in October 2020. It was a way in which we tried also to put with us certain important pharma industries because we think that their position, their interest was also important to know and to be included in a way or another in this consultation process. As a result of this, we published in January 2021 this position paper, which includes 11 key principles that I will briefly detail later. But the important thing is that this document from EURORDIS is not the result of the inspiration of somebody in a day of really thinking in the newborn screening, but it's the result of a consultation process where federations of rare diseases, national alliances of the rare diseases, experts on rare diseases, pharma industry, all these stakeholders have been associated to the process of producing the key principles for newborn screening. This is the document. The document exists in a lot of languages. It exists, of course, in Czech and in Slovak and in a lot of different languages. And very, very summary, what we identify as the main problems. First of all, of course, and this is a discussion that is always a discussion inside EURORDIS, but not only, is that the screening should be always referred to what we call treatable diseases. We don't screen for the pleasure of screening. We screen because we can do something. If we cannot do nothing, it's absolutely useless to screen and even to communicate to families that you have identified something, but you cannot do nothing. What we pretend is always that we should do a screening which has actionable diseases and treatable diseases as an important concept. Of course, it's very important that the newborn screening should be organized as a system with defined roles, responsibilities, etc., etc. And this is one of the most important tragedies, if I can say like this, in the field of newborn screening. I came from Luxembourg. In Luxembourg, we don't have any body at national level which gives, if we can say like this, the authorization for implementing a certain screening for a certain disease. We screen only 5 diseases in Luxembourg. Now we have expanded to 2 new diseases, the congenital cardiopathies and the SMA, but this is the result of a discussion directly with the minister, a discussion with the Directorate of Public Health. It does not exist, for instance, at Luxembourg's level, any authority at national level which is really responsible for the newborn screening. And this is not only the situation of Luxembourg. It's a situation, unfortunately, very, very common in the most part of the member states. If you don't have a very clear and identified system in your member state defining which are the responsibilities, which are the roles of everybody, it's very difficult to progress in the area of newborn screening. Of course, also the principles identifies the psychological, social and economic support as something necessary and also responsibility of the competent national authorities. We identify also that all stakeholders should be included at the different stage of the NBS process. We insist once again that even at the level of countries or regions, because the organization of the health systems in every member state are different, then we don't pretend to give a single model how you should organize in your member state, but of course that we want is that this system at a country or region should be transparent, independent, impartial and evidence-based process. Of course, we think that the governance of this newborn screening program should be explicit, comprehensive, transparent and accountable. And finally, that it should be a process very clear of inclusion, exclusion of diseases in the newborn screening programs that should be based on best available evidence. Information and education, timing, sample collection, methods, identification, etc. Appropriate safeguards for the data protection and data access in place. And finally, that the different European reference networks, affiliated centers, should be integrated in the care pathways for the different healthcare systems. That goes beyond even newborn screening, but for us, the role of the 24 ERMs are absolutely important. What is maybe now important also is to define precisely what we can do after this meeting. What we can do in order to promote, expand, extend the newborn screening in all the different, at the European level. From one side, it has been very well explained before by the colleagues of the International Society for Newborn Screening. We need a sort of expert forum. We can give the name that we want, the European Network, Expert Forum, etc., etc. And it was very nice that the colleague from the Statistical Institute here in Czech Republic presented the experience of the cancer screening, because this is exactly the experience in which we want to base what we want to do. I was associated to this when I was in the Commission, and in the case of the cancer screening, I remember in the case of breast cancer, we started a process of selection of experts in breast cancer in order to create this network of cancer experts in order to produce the guidelines for cancer screening, breast cancer screening, and we selected 200. But as you can imagine, in the case of breast cancer, you have experts on breast cancer practically everywhere. And then it was not so complicated, and after we were forced to organize elections by groups, etc., etc. But I mean, the experience of the creation of the what was called Breast Cancer Initiative, and after Colorectal Cancer Initiative, under the initiative of the GRC. The GRC is the Joint Research Center, which is a general directorate of the European Commission, is exactly what we want to do. If it has been possible to do this for breast cancer, for colorectal cancer, and for cervical cancer, why is it not possible to do it for newborn screening in the case of rare diseases? Because the experience exists, the methodology exists, the body for doing this, the GRC, exists, and this is one of the things that for us as Eurodis is most important, is of the utmost importance. We have been in contact with the European Commission and with the GRC. I think it will be very, very positive if we don't do everyone his contacts isolated. I think if we can do it together, International Society for Newborn Screening, Screen for Rare, etc., we can do together and in cooperation these contacts with the GRC and with the European Commission. I think it will be much more productive than doing everyone his own effort isolated. That's, for me, the most important thing, because if we are able to create this European network, it will be something really important. For the rest, the steering group of promotion and prevention has been mentioned also before. The function of this group is really endorse what they call best practices. It's important that the newborn screening should be recognized as best practice, and it seems astonishing and even really stupid that something as the newborn screening existing from practically 50 years is not included in the database of the European Commission as best practice. Okay, we need to do this. And this is a responsibility of the representatives of member states in this SGPP. The steering group of promotion and prevention is composed by 27 representatives, one by member state. In every member state, you should identify in the Czech Republic or in Luxembourg or anyone who is representing your country and try to do the necessary lobbying, if I can use this word, in order to obtain the recognition of the newborn screening as a best practice by the SGPP. Of course, the immediate consequence of this is that the European Commission includes, if it recognizes as a best practice, in the EU for Health Work Plan for the year 2023 or 2024, the newborn screening is included in the work plan for one of these years for receiving funding from the EU for Health. Could us maybe have the organization as a joint action. This is something that it could be discussed, which is the best model for doing this. And finally, of course, is always what you can do directly with the member states and with the European Parliament in order to obtain the necessary support for this. Okay, that's a little what we are trying to promote as Eurodis. We more or less exposed our ideas in the Slovenian technical meeting on NBS, which was very recently. We are trying also to promote this best practice, newborn screening as best practice, using the Italian model. Maybe we can use another, but it was the case of the Italian model because they include 48 diseases, etc., etc. I will not really explain you, but this was our effort in order to influence the SGPP for obtaining the recognition of newborn screening as best practice. And finally, of course, is our support and involvement as much as possible in the Screen for Care project, which we consider a really brilliant project for the coming years. Well, that's finally what reactions, messages of support that we have received. I think it's important because really what we are doing is not something that it's not recognized by nobody. It's recognized, it's accepted, it's supported by a lot of persons and by a lot of associations. That's important. And as I said, we have the key principles for the moment available in 12 languages, including Czech, and of course available in all the languages in the website of Eurodis. And that's a little the same thing that I have presented to you: collective effort, dialogue, collaboration, work program 2023 for the EU for Health, best practice, and newborn screening as best practice at the European Union level. These are the things, concrete things, that I hope that we can find space and ways to proceed for doing these things a reality and not only an intention. Thank you.
Happy to be here on stage again. I feel like my sister, who was a professional ballet dancer at the Royal Opera in Stockholm, being on stage so much. She loved it. I kind of like it more and more. Anyway, so I'm going to talk about something else that I've been very, very much involved in, and that is registry. You heard the work from Stefan Köker. They have been doing so much nice things, I think, over the years, and everybody in our field know the work from Heidelberg. And some of you that are listening have been involved in some of the European efforts trying to do registries, which I think is really, really key. And especially for countries like ours, like Czech Republic and Sweden, that has like 10 million inhabitants. We really, really need to collaborate. I mean, we've been talking a lot about this. So I'm just giving you a little bit of what we have been doing in Sweden and the way we have been pushing to make a system that works clinically and also interacting with patients. And I'll show you some of the work. So, this is just, I don't have to spend time to say that I work both in a laboratory housing both medical diagnostics, biochemical and genetics, as well as newborn screening. But I, from time to time, run to the pediatric clinic still, even though I don't do it as much as before, but approximately 20-25% of my time. So this is the lab I work with, and I think collaboration again is key here, getting the disciplines together. So the Swedish newborn screening laboratory, there's one screening laboratory in Sweden. We screen approximately now, I saw the numbers from Czech Republic, 110,000, and we have now approximately 117,000. But we are still happy that children are born in our countries. I realize the situation has changed and dropped dramatically, for example, in Portugal. They had approximately the same numbers as we had, and it has dropped tremendously, and I think it's the same situation in different countries. Anyway, so we have a follow-up also, and now I talk about follow-up in filter paper cards of approximately 1,000 patients with different disorders, such as, for example, CAH, but also PKU, and that is very, very important, and I come back to that later. And so we have had a very nice situation in Sweden where we have a biobank we have samples stored since 1975. And that is also something that has been really, really, really important for us, especially a country like Sweden, a small country that we have been able to store. So we have a lot of nice filter paper cards stored in our biobank, and that has actually enabled us to do a lot of things ahead of starting a national screening program. And that was actually the whole idea when the visionary person, Lars Hagenfeldt, one of them, that sort of made this happen and sort of made it possible, according to the laws, also to store the filter paper cards. So the ongoing Swedish program is 25 diseases at present. We have the endocrine disorders that are referred from the laboratory to different clinics in Sweden, and mostly referred by either me or my colleague, so that we can advise them how to take care of the patients on a Friday night, for example. And then, because it's not always, of course, a pediatric endocrinologist you find on the other side of the telephone. When it comes to SCID screening, we refer to one of 3 specialist centers in Sweden. So all the positive screening cases are referred to either of 3 places. When it comes to the metabolic disorders, we have 4 places in Sweden that we refer all the screen positive cases to. And approximately 100 children are found per year that are true positive cases. And we will not talk about what true positive cases are anymore now. And this is really what my talk was going to sort of focus a little bit about, and what we have tried to do, which has been very complicated, both for technical reasons and for legal reasons. So what we have is, if you go from the start here, incoming DBS sample, and then we have scanning of the data, entered into our LIS. We have a sample analysis done. Everything is introduced to our laboratory chromatography system. Yeah, thank you. Thank you. And then, so we have this clinically evaluation of the screening sample. Is it a screen positive case or not? Those cases are, as I told you, always referred. So if you have a new sample taken, those are referrals in our setting and situation. And so then we have the workup from after the referrals with the diagnostic testing, and whether they are positive or negative, they are entered into a computer system. Those that are positive, that are confirmed, diagnostically confirmed, are entered and exported to our registry. So as soon as I find out that this is a true positive case, I push a button in the system and the data is exported. So you have personal data and you have a lot of screening data. Very often also you have the genetics, since we perform a lot of the genetics as well. And this is sort of a little bit of the key, that the newborn screening system enter data into the same technical platform where we have the registry, the national registry. And so this is the registry, the name of the registry, and a typical national registry without even an English site. Now my colleague Lena just produced an English short version, but otherwise this is in Swedish. But so we have this, and we started and got national funding in 2012, and we started to use the registry 2013, when the first patient was introduced into the system. And now we have 46 diagnoses included, and we have, and that was the key principle here, that we have all the metabolic disorders that we screen for here in this registry. But when it comes to other disorders, we have other registries in Sweden, and we try to also collaborate. A lot of the pediatric registries in Sweden have the same platform, actually. And then now we have also porphyrias, and we have some neurometabolic disorders introduced into the registry. But as soon as you introduce a new disorder, you need to get the network of clinicians and people so that you can sort of get the right data introduced into the system. So here is the caregiver's view from this registry, and this is what I always open up together with a medical record when I see a patient at the outpatient clinic. So here you can see you have some baseline data, with mutation, disease, disorder, and you also have ongoing treatment that is on this. And here you have parameters that you think are important to follow, biochemical parameters. And for example, when it comes to the registry for rheumatologic disease, they also have a scale for pain. So you can see it on the axis, and you can see it over time. Most of the medical records are terrible if you want to visualize things over time. And then you introduce different things also, and you can have life of quality things and data like that. And this is actually the main sort of focus, I think, for my talk. And this is what we had a lot of struggle to do, but finally succeeded in, that we also now have a patient's view. So the patients can log into this system, and they can do it and look at their mobile phone or on their computer, and they can see some data and introduce some data. And the thing I want to highlight here is that there is a possibility for the families to introduce quality of life instrument type of data. So we have DSAB Kids, we have a PKU quality of life instrument, and we also have round 36 at present. And the nice thing about this is that we can tell the family, before you come to us this time, please fill in this form. And when I open up my view that I showed you previously, it would say new data introduced by the family. And then I can see that. And I think that this has meant and been extremely important to me, because I think very much of the medical sort of, the visits has been so focused on different things that sometimes you miss, especially, for example, with teenagers. You realize, oh, this teenager is extremely unhappy. I didn't really realize that, because on the short visit with the mother or father talking all the time, it was not really evident. This is something I think is very important. So we try to have a life quality introduced at least once a year. And another thing, and this is also something, the life of quality, we also have iPads, for example, or tablets, I would say, that you can introduce when you sit and wait in the waiting room. And so here's another view from this patient view, where they can go in and see their own phenylalanine values over time. And this we have sort of designed in a way so that it fits the different disorders, so they can go and look at the different data and look at that from home or from their mobile phone. And this has actually revolutionized the system now. Because when we started this, we send out this paper, and you know, postal service is not perfect anymore, I think, and it takes a very long time. So we started to first introduce this to all the metabolic centers, but then the families called the metabolic centers and asked for the data. And then we finally managed to get it to the patients. And now, of course, as soon as we produce the data in the lab, phenylalanine value from the filter paper, it will immediately go into the family. So they have the data immediately, which I think has been a fantastic improvement. And lastly, I just like to say something, and I don't need to spend time. This is just a summary of looking at the data and try to see, are we successful in treating the patients with PKU in Sweden? And at present, this was an analysis done by approximately 300 patients, seeing that we are doing pretty okay, I think, at least with the children. So I just stop by thanking some. I mean, this has been a complex journey to build up this thing, but and I also like to end by thanking some of my colleagues that I work with in the lab, and here is Lene Sørensen, who has been working tightly with me since we first actually wrote the application to get funding, which was in the end of September 2011. That's when we wrote the first application to get national funding. So thank you all for listening, and I'll end with that.
Hello everybody, I'm the last. I will try not to be, too massively annoying, but I'm very happy to be here. So thank you very much, Victor, and all the organization for having invited myself. And my role, so I'm happy to present you the EU project Screen for Care. You see here starting. So to get on, this is that, exactly, but it does not work. The big one, no, the big one is going. Laser, yeah. Can you use my, yeah, but it's very small, but don't worry, I will use my finger, no problem. So, so Screen for Care stays for shortening the path to rare diseases diagnosis by using newborn screening and genetic newborn screening together with digital technologies. This project basically is a very large partnership, based on a very large partnership, and was funded by EU and IMI. IMI is the Innovative Medicine Initiative in Europe, and that is, this is a very new scheme of funding where EU and FPA partners, so the European Federation of Pharma Companies, are co-funding projects with very high translatability and impact on health. Indeed, you see here we have a very large 35 partners from academics partners and several universities in Europe, but also we have many companies, including just, for example, Illumina, Novartis, and Pfizer, which is the co-leader of the project. So basically, this is definitely a PPP, so public-private partnership, which is engaged in planning and defining how we can perhaps propose the best scheme for carry on genetic newborn screening in Europe and possibly not only. So the next, just briefly to say that I am this one, so I'm Alessandra Ferlini, and I have the pleasure, the honor to be the scientific coordinator of the Screen for Care, but together Pfizer, so Nicolas Garnier, who is the project leader and the director of patient advocacy in Pfizer. This is a rule in EU IMI, so the project, all work packages, all activities are co-coordinated by one from the academic side and the other one from the company side. And that's quite interesting in terms of way of working together, because the point is try to apply a strategy, a win-win strategy, so in order to get together, improvement from both sides, so science, health, and also industry side. So, which is the vision of Screen4Care summarized in 3 main pillars of activities, which are the federating all the complex ecosystem of newborn screening in order to putting together a massive number of data. So it's a sort of scanning of what is existing already on newborn screening in Europe. Second pillar is performing newborn screening. So this is a very big challenge for us. Indeed, you will say that in a while in more detail. So we will do a genetic newborn screening based on panel, and you see also we have an approach based on whole genome sequencing for several rare diseases. And the last one is to also think about adult patients, so ACP cycling, try to design digital tools that may help patients, but not only, also stakeholders or clinicians, to better address the path of that disease in order to get a very early diagnosis. So among several milestones, I wish to show you these are the main. As I told you before, that is the landscape analysis. So this is a sort of knowledge, improving knowledge about what we know already about newborn screening. You see here again, the leaders are, the University of Bern in Swiss and Pfizer, and we hope, based on that, to be able to provide recommendations about regulatory, data protection, and legal and ethical aspects of newborn screening. Then the second one is the running for newborn screening. I don't stay on that because I will tell you in a while, which is coordinated in terms of work package by University of Freiburg and Sanofi. And then establishing these 2 tools based on artificial intelligence, which aim at identifying new algorithms that can be, we hope, put for the sort of virtual patients in an app that can be widely used by all stakeholders with rare disease issues. And we are very happy to have Eurordis, as Tony has mentioned it before. So Eurordis is a full partner of the Screen4Care. That was a very important process we have taken into course during the negotiation, and we are very happy there is also Gulsin there. Now we have Edith Gross as a leader. And the voice of patients in the Screen4Care is not just an actor, it's just not a participant, it's a central voice indeed. Eurordis is involved in work packages. So work package 1, very important. The work package 2, designing the actionable diseases genetic panel. This is a huge issue, big challenge that we are so happy that Eurordis is taking on charge. And then also in the third, so the 5th work package in terms of designing the algorithm and the app addressing patients toward a shorter diagnostic pathway. So just to show you, I don't go into detail, this is the general scheme of the Screen4Care. Of course, this is a very complex project, 35 partners, many companies, but just to put your attention on the number of work packages, because I will explain you briefly each of these. So 1, 2, 3, 4, 5, and 6. So as anticipated, work package 1 is very important because it's taking care about legal data readiness and stakeholder engagement. As it is a sort of, backbone of the Screen4Care, providing data, collecting data, and considering all issues that might, very important ethical and legal issues that are related to newborn screening, and as you know. So interacting, of course, with all other work packages, we are highly interacting and with transversal activities. Number 2 is the work package is collecting and acting as the Screen4Care repository, data repository. So in order, using new data model, data with high interoperability, so that would be a sort of a core of the Screen4Care where our data will go in order to get the final view and the final data set. Of course, we are mostly today interested in the newborn screening by itself, which is in work package 3 with several tasks, 6 different tasks, and you can see this task in detail here. Of course, you see here the core tasks, so designing a panel for treatable disease only, so that's something that is in due course. So we are defining criteria on which we will base on our design. So it will be a gene panel, but very accurate, so also picking up small variation, copy number variation, everything. Indeed, we have 2 partners specifically working on CMV's a new algorithm. And then we will design, and Eurordis will design a panel called Actionable, including theoretically many disorders, so disorders which are not treatable with the approved drugs, but highly actionable. And that will be so interesting to see which will be the prioritization of these diseases based on your survey on barometer. And then also all the other aspects, including that task, which is interesting in our approach, I think, which is the whole genome sequencing that we will apply not at the MBS level, but in the early symptomatic level. So in those infants which resulted negative on the newborn screening, but then we will follow it up for 2 years in the project, and we will do whole genome sequencing, in case of early diseases, early symptomatic infants. And then that's a very other important cost. We are already working on that, on cost effectiveness. So cost that we have to face in the future for MBS in terms of activity. So, as I told you before, this is ongoing. Treat panel is very close to be finalized. We have a specific group on that. Actionable diseases panel is based on Eurordis activities, and whole genome sequences pipeline and clinical follow-up is also under study. I would underline that we are very happy to collaborate with so many similar initiatives. We have Jim here, Jim knows, already working with Genomics England, with baby sex. So, as I said, underlined before, NBS, or newborn screening, should be highly, shared in terms of people working on this specific field. So, as you can imagine, we have very heavy ethical tasks. So we are already presented the ethical application for number 1 and number 3 now, and we are very close. Well, of course, for the actionable, we have to wait for the survey. And then we are progressing in having all the ethical approval for the specific tasks of the Screen4Care. So just to show you that we are paying a lot of attention to ethics, because that might be a issue that we for sure will encounter when NBS will be hopefully very soon in the clinical practice and in the best practice activities, as suggested. Another point I would like to mention is that based on cost studies, we are realizing that definitively newborn screening based on genetic screening, so panel, definitely is much, is more effective if centralized in a hub. And this is what we are doing in the Screen4Care. So a little bit different from what we have planned during the project preparation. Our future is here, so probably we will identify a hub center which will sequence and carry on all the genetic analysis for all 20,000 infants we are planning to screen. And quickly, the last work packages, just to show you the number 4, is focused on algorithm for exploring electronic health records. That's another interesting aspect in order to compare data in the various countries in Europe and to try to harmonize also collection of data and data entry as, Rolf very nicely showed before, in a sort of self-registering, self-data registering information, which I support a lot. I like it a lot, that approach. And 5 is the developing of an app. So this is a pure digital work package coordinated by Dublin University. And of course, number 6 is the normal project management, which is quite complex. I'm going to the end. We are highly inclusive in our governance. We have many boards. We have multi-stakeholder boards. We have scientific advisory. We have ethical boards. We have dissemination board. This is just to show you which is our vision and our mission to work together with many other similar activities and initiatives. And finally, what we hope to have in terms of impact on health, of course at birth, based on our newborn genetic screening, at early onset stage, using, of course, our whole genome sequencing and algorithm to flag patients with early symptoms, and ACP cycling in all stages of life, of course, using our digital symptom checker we will develop within the project. So basically a strategic landscape of many different initiatives and platforms. And thank you for that. These are just our flags. So follow us on these various social networks and our website, and just contact us. We are happy to stay in touch. Thank you very much.
Of the Precision Medicine Network of Western Norway and Professor in Medical Genetics. And Professor, the floor is yours.
Thank you very much. So I am here really representing the European Society of Human Genetics, where I'm now the treasurer, but I've been the president and GenSec. So I'm going to talk a little bit about the IVDR in a short while. And my reason for talking about the IVDR is because, we have talked about newborn screening here, and either this can be done primarily on genetic term by genetics, or genetics will be an end result of such screening. And the IVDR is the regulation of genetic testing in Europe. So this is something that concerns us a lot. So this is a regulation that was implemented in May this year by the EU. Next, please. I think if I can get this one. Thank you. So this, the regulation of laboratories in the EU is through accreditation, and then you have a medical device regulation, and then you have the IVDR. So the IVDR is not only regulating our testing, but also the software that is used for testing. What is a little bit of a problem in genetics is that we really never asked for the IVDR, because we didn't have any big problems that needed to be solved by a thing like this. We were concerned about direct-to-consumer genetic testing, but for the problems that we really have, which concerns data sharing, and the problem we call the VUS, which is variants of unknown significance, the IVDR is not helpful. And then the second problem we have in genetics is that most of our tests, 90%, are laboratory-developed tests. So we make them ourselves, more or less. Of course, the IVDR has a very good intention, which we support. So that is to enhanced quality and that all genetic tests and other tests should be done within the frame of the healthcare system. The problem, from our point of view as geneticists, is that an apparently convenient means to obtain this is to demand industry standard CE marking of all tests done. And the CE mark tests are not necessarily better than the ones we do ourselves. And the second problem is that not that many are available so far. But we are positive to this quality regulation. The problem is our own tests. And in order to do them, there are some requirements. And I have highlighted the problematic parts of this. So we need to document that our own tests are at least as good as the CE marked tests. And we need to justify their manufacturing, their modification and use. And this requires a lot of effort in these laboratories, which are mostly public laboratories. And this is very demanding and will need a lot of manpower. And also to control that we are doing it the right way, we'll need a lot of manpower on the level of the authorities. So this is challenging. You can say that if a test is a CE mark test, it's a kind of a little bit of a black box. So it's convenient, but very inflexible. And we need a lot of flexibility to diagnose rare diseases because the genetics behind rare diseases is exceedingly complex. Second problem is that it's very expensive to get CE marking, especially for smaller companies. And no, there are just 7 certification bodies in the whole of the EU, and they have a long queue. It's also expensive to get our own tests CE marked, if that is a requirement. And we fear that we will also run into a monopoly in the future, which will reduce our flexibility. So if CE mark tests is what we have to use, then we don't need our big staff of very competent molecular biologists anymore to do our own testing, and then we lose our flexibility. And this will increase costs, no doubt. We don't know how much. And why is health care cost irrelevant? Because it's not mentioned in the IVDR at all. We lose flexibility, and we have learned from COVID that that is essential to be able to turn around. And also the in-house qualification is not very important, because to be accredited is not compulsory after the ISO 15184. So, from our point of view, concerning genetic testing, was there ever a big problem that the IVDR needed to solve for us? And my answer is no. This will increase our cost. The bureaucracy, can lower our competence if we are not allowed to keep our staff. And really nobody wants it. Not even the big companies wants it. So why do we have it? It's a little bit of a problem, but we are working on it. So we have published a statement that you can find on our website, and that statement has been endorsed also by other societies, like the Society of Microbiology. So that's all I want to say.
Now we want to give the floor to a very important person for us, which is Stelios Kimporopoulos. He's member of the European Parliament. He has been elected in 2019 by the party New Democracy, which is a party affiliated to the Popular Party or Popular Group in the European Parliament. Stelios is a person also which is very active in the ENVI Commission. You know probably that the Commission ENVI, which leads with the topics of environment and health, is one of the most powerful, important commissions in the European Parliament. And finally, he is always a person available that we can always ask to him to cooperate with Eurodis, now with the Czech presidency. Then it's a real pleasure to have Stelios with us today. Stelios, please, the floor is yours.
Thank you so much for the invitation. I hope to hear me. I don't know if it's the sound great. Thank you. And I'm very glad that I'm here today, and I'm very happy that the Czech Republic presidency has raised a very such important topic, and it's one of its goals to succeed during the 6-month period. And I would like to congratulate for today's meeting. I think that we have heard different aspects of this issue, but I would also like to raise some points, and I think that we need, as politicians, need to talk about early detection. So how much important is to go under a law regulated to have early detection, early diagnosis and intervention, because we need to prevent impairment or even death. We have heard some minutes before that with some very costly interventions can we change the lives of the patients. So why don't we see the potential and the results of this early detection and newborn screening? Yes, the newborn screening picture varies greatly between different countries and regions. In some, screening is mandatory, while in others conduct no screening at all. So we need to find, to regulate and to try to put into implementation for all countries to have a minimum standards on rare diseases. The development of appropriate, well-organized and equitable newborn screening offered on a voluntary and default basis. I think that on a European level, we have the opportunity to create a change of data through the European Health Data Space. And we have the statement of Mrs. President Ursula von der Leyen that we need to build a European health union. So I think that this is the opportunity. Newborn screening is important to raise awareness and thus give more incentives to companies to invest in research and production of orphan drugs. In a few months, we will have the revision of the regulation for orphan drugs. But my question is, and I will finish with that, what is happening after the diagnosis? It is important to have early access to treatment and the necessary support to achieve not only treatment, but also social inclusion. There are different barriers among the member states, but there might also be different needs. So we need to take all relevant factors into consideration to achieve equal access and treatment among the member states.
Well, thank you, Stelios, for that beautiful contribution. And we continue with Martine Pourjean. Martine, we've known each other for a long time. You're the IPOPI president. You are, as for a Screen4Rare founding member, as we've mentioned a number of times today. And you also have an ERN RITA commitment, namely in the patient journeys. Actually, the same questions for you. So what do you think is important to this meeting from the perspective of your organization? And also, what do you think are the biggest takeaways of this meeting?
Yeah, thank you, Peter, and thank you to the organizer for having me, even if remotely, because the airline company has decided otherwise than myself. And I miss you all, and also the museum visit. Anyway, I think that this meeting is really excellent, and that we heard a lot of excellent things. First of all, my take out of that is that newborn screening is a system, and we believe very strongly in that. There is a before and there is an after the test, and as MEP Stelios just highlighted, the after especially means access to treatment. Because we speak about access to newborn screening, but also access to treatment after that. And we know that, for example, for the condition that I represent, meaning 500 rare immunological diseases, primary immunodeficiencies, among them SCID, we know that not every country in the EU has access to the treatment. So that would be the first point. The second point is about the genomics revolution that Jim highlighted this morning, and how it will enhance preventive medicine. I think this is very important to raise awareness in that, because even the decision makers are not always aware of the possibility that it offers or will offer, and that we need to raise awareness in that. The third thing is about the registries. And here, of course, we all know the value of data, and also historical data, the value also of interoperability. And I was really interested about the self-reported patient outcomes, because this is something that we value very much. We believe that if we want something that is truly patient-centered, that we need also to gather those real-life data, and that those registries should more and more allow that. I think also that collaboration, of course, and this has been highlighted by many of the speakers, is really paramount. And therefore, I think also that the support of the EU should very much focus on how to disseminate what is done here so it benefits there, and how to not reinvent the wheel everywhere. And also this means that all of us, we have to raise awareness and also have advocacy actions to make policymakers, not Stelios, because we know he's very well aware, but some of them, or many of them, would not be so much. A patient-centered, this is also the angle stone, but this is something that is more and more said. I have to say that we need now to put it really into action, and we have had today, once again, very good example on how it can be done. And my last point would be that I believe that rare diseases could be also a very nice model that would be transferable for many other diseases, even for not so rare ones, because I think that what we do in our cooperative way must be really helpful for the medical community, the patient community, the politician community, the industry, of course, and the other, and I don't miss, of course, the experts on who we rely very much on ISNS as the best example. That would be my take away from this meeting.
Well, thank you for that, Martine. And I'll give the mic to Tony again.
Thank you, Martina. And now a similar question with Dorica Dunn. Dorica is member of the board of EURODIS. She has been the founder of the National Alliance for Rare Diseases in Romania. She has been also the founder of NORO, which is the organization leading with Prader-Willi syndrome. A very experienced person, and we ask also, how is your feeling about what we can do about MBS?
So I will address in my presentation also this question, because Romania is not, I'm going there to see my slides, if you don't mind, sorry. I'm coming from Romania. Romania is not a good example for newborn screening. We are having only 2 rare diseases in the screening, PKU and CF. And this is a problem, and I'm always shamed because of this situation, and I think this is a failure of my activity in the rare disease field. But I really hope that in the future we will change this situation. I'm involved in the rare disease because most of the leaders in the patient organization, I have a daughter with Prader-Willi syndrome. She is 37 now, and she was diagnosed only when she was 18. So this is why we started this movement in Romania, because we wanted to change the situation. We started in 2003, and we tried to do services for those who have no access to treatment in Romania. This is the situation. In Romania, patients are encountering a lot of obstacles. We are rare, but we are many, because Romania is a big country. We have more than 19 million inhabitants, so we should have more than 1 million patients with living with rare disease. If we consider that each person, not only the patient is affected, but the entire family, we can't consider that 20% of the population is affected by rare diseases. So 4 million of our people would be affected at least. 90% of the patients are still undiagnosed, and in Romania, more than 50% of the population live in the rural area. So in the last years, we were thinking how we can support these patients which are isolated and sometimes are poor and don't know where to address for support. Also in Romania live more than 20 different nationalities, and the rights for all is the same. We have the same rights. We can't consider that any nationality have a different right, because in the Constitution of Romania we have all the same rights. So as I said, we have a low number of rare disease in newborn screening, just CAH and PKU. We have 5 centers for screening, and we have a national registry for screening. We are talking a lot about how to improve the situation in Romania, and we are thinking about expanding to more metabolic disease, and we started our discussion with Maurizio how to improve, and with our centers of expertise, and we hope to progress in this too. Of course, if we don't screen patients, there are delaying access to treatments, and not only for this, but also because the genetic testing, sometimes we don't perform enough genetic testing. We don't have a national program for genetic testing. And the waiting time for diagnosing of the patients is more than 5 years. So we have the same rights, all the nationalities in Romania, but we have different realities. This is the situation. And when we are considering and we are debating a national strategy for health, we don't consider the cultural difference. So we should consider, and I'm happy that this time the national strategy is under debate now, and we considered to have more integrated care strategy for health, and we took into consideration more about cultural diversity and vulnerable people. And because they have specific challenges, of course, the experts have more problems regarding monitoring their healthcare status and with compliance. Sometimes their access is limited due to their because they are poor and they can't go to a university hospital to be cared, or don't know about the hospital because they have not enough care. We don't have enough care coordinators. Anyway, the situation is bad, but in a way, we also have a lot of achievements in the last year, so we work hard. We have the third national plan now that should be integrated into the national strategy for health. And as it is in the debate, we know that 8 of the objectives are referring to rare disease, which is really great. And the first national plan for rare diseases since 2008, and even if it was not really implemented and it was not part of the national strategy for health at that time, we succeeded to have a national council for rare disease and to progress and to convince the Ministry of Health that we have to take action. And in 2011, we opened with Norwegian funds a Neurocenter. And I will mention Neurocenter because it's my biggest achievement as a person. It's a center for rare disease in Romania, and but because it is bridging the gaps between patient organizations and professionals in Romania, we are collaborating with all the centers of expertise in Romania, and we have 32 centers of expertise accredited in Romania now. So we still have challenges because many rare diseases are still undiagnosed or diagnosed late. We have a small number of specialists in 6 regional genetic centers. Also, the patients are lost in the healthcare system because we use ICD-10, which don't cover all the rare disease. A lot of the rare diseases are not covered, so we can't find them in the healthcare system. We don't have a national registry for rare disease, and no legislation for integrated care. We talk a lot about the fact that the patients with rare disease need integrated care, but we don't have a legislation. And we have different ministries which are not always collaborating. Prevention services are lacking, and there is a cultural diversity. We have 20 nationalities, as I said, and we have to take care of diagnostic care and monitoring difficulties, lack of compliance sometimes, and the level of education. And we have to support them as much as we can. So we are screening only 2 different rare diseases, but the innovative treatments have been updated many times, more than 20 times in the last years, but we still have a lot to do. These are our achievements, and we are proud that we achieved to have the centers of expertise accredited, and more than half of them are part of the ERNs, including our center. And we have registries at the level of centers of expertise and a good collaboration between patient and experts in Romania. So I would say we need a systemic approach. And because of these delays and this lack of expertise and the collaboration and the care coordination, we need to address the care coordination in Romania. And after implementing Enough Care, some of you might remember about this project, we were testing a holistic approach for patients with rare disease, how to bridge the gaps between health and social care for patients with rare disease. But we didn't find resources to have case managers all over the country. And we identify in the healthcare system in Romania the community nurses that could do this because they are working in the rural areas too, even in the most isolated places. And with a proper training, they could manage to understand when a patient has a rare disease, to orient them to the centers of expertise. But we have to put them in contact. So we accredited an ECHO training, which stands for community extension of community health outcomes. And we started to train community nurses in Romania with, of course, having a partnership with Ministry of Health to do this. We have trained about 400 community nurses. We have in Romania 1,850 community nurses, and we will continue their training. And until now, they identify, since we trained them, 937 patients with rare disease and orient them to the centers of expertise. Because in our training, we invite centers of expertise to be connected with the community nurses, and they know that where to orient the patients. So not that we don't need that specials, that doctors, because in that graphic is when a patient is sent from one to another doctor and they don't find the diagnostic or the care. But at the level of centers of expertise, we have interdisciplinary teams. So if they connect the patient with the center of expertise, the waiting time is shortened. And this is our approach for supporting more patients and even most isolated patients in Romania. Thank you very much for your attention.
Yeah, thank you very much. So I'm not going to repeat what Tony said, but I would just like to highlight the fact that we are the umbrella organization for rare diseases in Europe. And what we do is that we empower and advocate for a rare disease community by bringing rare disease patient communities together with different stakeholders and trying to advocate for changes in the rare disease policies. So with regards to newborn screening, we also work with national alliances and we support national advocacy on the national level in newborn screening with developing tools together with them, like the tools that, the newborn screening principles that Tony has mentioned. We're also doing surveys on understanding the perspectives and experiences of rare disease patients, like they're called rare barometer surveys, and we have recently done a survey on diagnosis, which I will explain a little bit later, but we're also contributing to the Screen for Care project, and we are also going to do a survey on newborn screening. So we are thinking that the national alliances would use these tools as supporting their advocacy on a national level in order to reach to a harmonized approach in newborn screening in all the member states in the EU. So this shows that rare disease patients recognize the positive impact of newborn screening and its contribution to disease prevention, treatment, and care. And the second thing that I want to mention is the diagnosis survey. So this rare barometer survey that we do to understand the perspectives of patients living with rare disease. So we have surveys on access to treatment, participation in research. So this one is on diagnosis, and we asked them what are the consequences of obtaining a diagnosis. And we have been doing this survey since March, and we finished in June, and we have started analyzing the results. And I would just like to mention some of the results that are that I think they're important. So we have had 13,000 respondents to this survey. People responded from 107 countries, and almost 2,000 rare diseases were represented. So the survey confirmed us that rare disease patients face multiple challenges, multiple difficulties, and also significant delays in obtaining a diagnosis. So this is not a surprise. And the survey also confirmed that having a diagnosis improved access to care, access to treatment, and also to the clinical trials. And from a social perspective, it also increased integration at work, at social life, and also access to financial resources as well. And also the third thing that we have taken from the survey is that a center of expertise brings significant improvement to the diagnosis journey, also shortening the diagnostic odyssey. So this is why we think that newborn screening programs, when we think of that as a system, not only as a test, like Maurizio said, they could help refer these diagnosed individuals to the expert centers, which would help improve lives of people living with rare diseases. So these are little facts. The analysis is continuing, so we are going to publish the results of the survey at the end of 2022, and we are also going to analyze the survey results according to countries, according to diseases, and according to ERN groups. So this is what I wanted to say. Thank you very much.
Thank you for that, Gulshan. So there's really just a few minutes left, but I do want to consume those, at least for two short questions and maybe with preferably short answers. And the first one is to Dorica. Dorica, we've been listening today to a number of presentations on organizations, on techniques, on high-end next-gen sequencing. And then I hear your experience in a country with a screening program and 2 diseases. What are your thoughts on that? Could you elaborate a bit on the big resources that are taken away by developing new techniques and all the implications that cost money, and then your situation, please?
Yeah. So when we think about screening, it seems that we stopped in time. Because we didn't improve the situation, and we have a lot of debates around it, and I think all the stakeholders have to communicate better and come together and have a solution, because our centers and say that they have the technique to perform the screening, but somehow they are not recognized by the Ministry of Health, or they are not appointed to do this. And of course, we need resources, and we need a system to be put in place to coordinate the screening. And
so if the system would be in place, you would probably expand your screening panel.
Yeah.
With the number of diseases.
Yes, because we have a system, it's put in place for PKU and CF, but not for the genetic things. Yeah.
Well, thank you for that. And the other question is to Professor Hauge. Actually, the problem you pose, it seems to be really a bomb on the entire system. And I think you wanted to present it that way. Would it be a solution not to try to introduce, for instance, next-gen sequencing in the period of 10 years' time in newborn screening, but take one step back and wait until there is a population at risk, maybe at half a year or in a year when a baby's a year, and then based on symptoms on a smaller group, you could do much more with next-gen sequencing or next-gen sequencing-based diagnosis. That would be my question.
Yes, well, you know that when it comes to screening, geneticists are in principle quite, we are restrictive, to put it the least, because we know that if you just, let's say you do screening of all possible metabolic diseases on the genetic level, you will get a lot of uncertainty. That's the problem. So, yes, when it comes to a baby with a symptom, that's a completely different story. And there we want to introduce these very potent techniques as early as possible. And now I'm talking about next generation sequencing. So that's what we want. But that's a different scenario, because then you have a symptomatic baby, and for us it's really important to know the phenotype in order to interpret the genotype, because as was mentioned here, if we do just, whole genome or exome sequencing of anybody, here you will find a lot of variants you don't understand. So that is the challenge. Yeah.
Okay, Stelios, there is probably a question that is here. Do you think that really, from the point of view of the European Parliament, are you in position, do you think, in a certain moment, the ENVI Commission, to approve a resolution supporting the expansion and the extension of the newborn screening at the level of the European Union, or at least the creation of a European framework?
Unfortunately, in the moment that we are speaking, health issues are belonging to member states' competence. So, unfortunately, we have the authority as the European Union to create and to push to implement in the member states the same procedure. But on the other hand, I think that we can create a framework that puts the member states in a place that we are going to follow the good examples. And I think that as human beings, we are fragile, and unfortunately, we will always have diseases, rare diseases, and persons who are belonging to this category. So I think that we need to build a strong system for all member states, which will have early diagnosis, which exchange their data, that they will increase equitable access, and finally they have the possibility of raising awareness among their citizens to accept the rare disease patient. Finally, I would like to conclude that we need to create a strong social system in order to protect this group of people, not only before, but also after the diagnosis.
Evaristo Stelios.
And then we actually got a present of 5 extra minutes. So I think there's time for one more question, which is for Martine Perjean. I saw you raise your hand, Martine, so go ahead. And then maybe one final question if there's somebody in the audience that wants to ask a question.
Yeah, I think that we all agree on equity and on the fact that no baby is left alone. Behind within the EU and broader. But now we have to speak of the way, and I think that one size doesn't fit everyone, doesn't fit all, sorry. So, and this is also very important to keep that in mind. For some babies, they will be born asymptomatic at all, totally asymptomatic, sorry. But for some others, they will have symptoms as soon as they are born. So this is just an example, just to say that given the different settings, first of all, of the countries, but also of the conditions, or the families of condition, we have to take measures that would be flexible enough to support the countries and the condition groups in a sense that this is helpful for them, they don't reinvent everything, but also this is applicable for them. So they can make progress, and strongly I believe that more is not always better. And maybe for some countries, this is good to have good screening as a system, as we said, and better than increase the number of screening. This is what I wanted to say.
Good, thanks. And this is certainly aligning with the number of discussions that we already had in Screen for Air, and luckily a point that was already raised today.
Yeah.
I'm looking at Victor. Victor, is this a proper point to end? No, it's the final question is from Maurizio.
More than a question, is a comment.
It's a comment. Okay,
I think that you know, we are speaking about newborn screening in different aspects. And what, for example, from the case of Dorica, I think that we need to stress that there is no screening without a registry. And this is extremely important because, I mean, if you want to really make the newborn screening as a system, and for this to help the family in understanding exactly how to do and how to live with the disease, whatever it will be, you need to have the knowledge of what are the different aspects of the diseases. And without a registry, it is absolutely impossible to do this properly. So we need to link this concept that the newborn screening advancement will be conjunct by the registry empowerment that we need to have. This is why, you know, in the MetaVLN and also in other ERNs, we are pushing very much with the registries, and we are putting a module for the newborn screening. It is obvious, but it is not so easy, because you need also to have a lot of contribution by physicians and a lot of activities, which is additional to what we are doing. But we need really to link these two concepts together. And we need to think even at the parliament and the movement to push for the right usage of data and for the reusability of data. And this is very, very important to have as a message for that.
Well, thank you for that last comment. And I think that was also a point that was already a number of times made today. So thank you for that, Maurizio. I would like to thank our panelists, Gulcin, Sophia, Gunnar, and Dorica. And I would like to thank my partner, Tony, and with this, this panel discussion is ended.
And thank you so much for staying to the end on a warm day when it's lovely outside. I think one of the things that have been impressive today is the amount of agreement that we've had. You probably saw that in those talks at the beginning, which were separately prepared, but nevertheless reiterated the same themes. And what those themes throughout the day have told us is that we're looking for equity of access to newborn screening for our children. That doesn't mean, as Martine told us, doing the same thing everywhere, but it means doing the right thing in the right place at the right time. And the way that we tackle that, and this came out again and again, I think we can reach agreement about that, is considering newborn screening not just as a test, but as a carefully integrated pathway and indeed a pillar of our public health policy. It includes the boring bits of carefully defining what we're talking about and the conditions that we're talking about, so that we're talking the Esperanto of science, if you want. We're talking the same language and that we can understand one another. It would seem self-evident, but if you make a public health intervention, you would think, but we don't always do it, that you would check what effect it would have 1 year, 5 years, 10 years down the road. We haven't done that so well so far. We have done it in part, but long-term outcomes embodied in interoperable registries are becoming increasingly key. We need these things, and we need them because we've got to develop what we have, but also protect what we have. And in today's fragile world, we cannot take that as a given. We don't see it, for instance, in our vaccination programs. Uptake in vaccination programs in some areas is very poor, and yet that is an important public health policy. Thankfully, newborn screening uptake in all of our countries, when it's offered, is excellent, and we need to protect that. And we need to protect it while we reach out into some of these new technologies such as genomics. But because of that, we need to do that very, very, very carefully. Because ultimately, the basic model, the contract, the unwritten contract is, I come and take a sample from your baby, and if everything is fine, then I tell you everything is fine and you relax. And if something is wrong, then I tell you exactly and clearly what that is, and that results in an effective treatment that helps manage or put right that baby. That's the simple unwritten contract of newborn screening that we need to protect as we go forward. And we've got a good basis for doing it because we agree on the key aspects of newborn screening. And I think that's what's come across very strongly today. So with that, I'm going to pass to Rolf. Rolf is from Sweden, and of course, Sweden is the next country after Czechia to pick up the presidency. And of course, it's through that mechanism, through working sympathetically with our policymakers and politicians, that we can both protect, maintain, and progress newborn screening for rare disorders. Rolf.
Thank you, Jim. So I think the work that has been done by Slovenia and the Czech Republic is really, really great. It's amazing to see so many people caring for patients that are not so very well known to clinicians out there. And I think it is really, really important that we join forces and think about this and promote this work. What I do think also is that we need to think about those that we don't talk about here. There are always rare disease patients that we haven't thought about, and there are new coming up with the new generation and technologies that we have around us. From a newborn screening perspective, I thought it was very interesting to hear the talk from Mrs. Dorica Dan from Romania, and I would really like to have all countries within the European Union screening for at least congenital hypothyroidosis and PKU. And I think that this should be a main goal, to have all countries in the European Union to screen for at least some of those really, really basic disorders. And what those disorders are is always, of course, something we can discuss. But I definitely think congenital hypothyroidosis is one of them. Pretty easy tests, pretty well known what to do, very, very cheap treatment. Another thought also is that I think should also try to help some other poor families and children in the world, like all the children in Africa. I mean, there is, I think, as far as I know, only one coordinated screening procedure in Egypt, in Africa. And of course, there are so many children out there that could be picked up, for example, with congenital hypothyroidosis and being treated. Well, I should not spend so much time there has been many things said already, but taking on the task here from Slovenia and Czech Republic, I don't know exactly how to do this, but I think that together, I think that people in this room are a pretty strong team, and hopefully we can do something. But exactly how and what, I don't know at this moment. But I really, really enjoyed being here, and I think it's really a time to thank the organizers and the people here in Czech Republic for the fantastic work, collecting all the people post-COVID times and seeing each other, which I think is also wonderful in person.
Yes, of course, if I have the privilege to give you the last words, the first thing to say is thank you, Victor, thank you, Milan, thank you for all the team, all the Czech team. You have been really exceptional for resolving all the technical problems, the political problems, the logistical problem, the gastronomical problems. You have resolved all the problems, and that's really exceptional. Thanks a lot. I think also we should say thank you to Gregor Mendel. He has created the conditions a long time ago for permitting to be today here discussing about genetic things so important that he has not probably imagined it. But nowadays, thanks to Gregor Mendel, we are here discussing about newborn screening. And I think that is always the progress of the ideas, the progress of the action, and particularly the progress of the cooperation, the collaboration, the sharing of the knowledge, the sharing of the ideas. And I think that really is what we need to do in the coming times, because there are uncertain times, and without sharing, without cooperating, and without probably being together in very difficult circumstances, we will not reach the future. Then, thanks a lot again to the colleagues here in Czech Republic, and okay, we start the visit now.